Hi there, this video is to encourage you to think about how you phrase both your open and your closed questions. This can have quite a big impact on your time management and also how accurate your diagnosis and your patient-centered management plan ends up being. So how we phrase the question will determine whether it hits its target or not. You've got to know the purpose of your question, what information are you trying to gain, and think about whether the patient will interpret your question in the right way. And that second point really benefits from reflecting while you're consulting. So if you ask a question and the information you start getting back doesn't seem to match, I've often seen on videos or sitting in trainees moving on to the next question. But if you realise the answer and the question don't match, and the question was important, which I hope it was, otherwise you wouldn't have asked it, it's really important to rephrase that question to get an answer. And as well as doing that, have a think about how did you phrase the question, how can you phrase it better next time so this doesn't happen again. The other thing that can happen with phrasing and transparency is that you might get relevant information, but you might get a lot of irrelevant information. And again, you have got the relevant information, but think about how can I rephrase that question next time so I only get more relevant and less irrelevant information. And often that goes along with the transparent consulting, helping patients understand why you're asking the question. If we take a really common example that I see, and that's the weight loss red flags question. Pretty simple, you're looking for any weight loss in the last, let's say, 3 months. So if you ask, have you had any weight loss in the last 3 months, you should get the information that you need. A lot of the time I see the question, have you had any weight loss? Now, we know what we mean, and a lot of the time the patient knows what you mean, but a percentage of the time they don't, and you'll find out about 2 years ago they went to Weight Watchers and then their diet slipped and their weight went up again, and then they cut out pizzas and it went down again, and so you get a lot of information, and it's very hard to stop a patient talking when you've asked them the question. So that's a really good example of time management improving with better questionings. How we phrase open questions will determine how open they really are. So if you look at the first question of consultation, something like, how can I help you today? That's a really open question, and it's asking the patient to tell you anything that they want to tell you, and without any prejudice of you determining a certain avenue. If a patient only says a few words, it's important to then follow up with another very open question. So for example, can you tell me a bit more about that? Or can you tell me a bit more about what's been going on recently? If you try and narrow it down too quickly before you understand why the patient really has come to see you, it will end up in a longer consultation. So, for example, say the patient had said, well, I'm coming in to talk about my headaches and about some other stuff. And so the doctor said, tell me a bit more about the headaches. You'll find out for 5 minutes about the headaches, and then the patient may say, that's been sorted out anyway, I just need another prescription and Naproxen for that. What I was actually here was for... And so obviously that's a longer consultation because the doctor guessed too early where they're going, tried to narrow down the consultation. Questioning in consultations is often considered or visualised as working in a cone. So you've got the very, very open first question, and you're narrowing down, ending with a diagnosis and a patient-centred management plan. And then within the consultations, there'll be multiple smaller cones. So each kind of section of questioning you can think of as a cone, where you're trying to start as open as you possibly can to catch all the information that might be relevant, and then you narrow down to finish with a point where you understand that section. So a very open question would be, let's say, example of finding out what a patient has tried already for their condition. So a very open question would be, what have you tried already for this? And so that's not prejudicing the answer, that's not determining one specific area, that's saying anything at all you've tried, tell me what you feel you've tried already. A not quite so open version would be, what medications have you tried for this already? obviously a very relevant question, but can only find out about medications. And if we go to the far end of the spectrum, a closed question such as, have you taken paracetamol for this? It's kind of a relevant question, but it can only find out about paracetamol. So my suggestion would be, when you're consulting, have a think, is this a new section I'm moving on to? If it is, how can I make the question as open as possible, and then to narrow down? So to make it a cone, you've got your very open question of what have you tried for this already? And then the patient may say something and you say, and how did you get on when you used that? And then you might finish with a closed question, is that something you carry on doing? And then you've kind of finding out, started anything at all, how well does it work? Do you want to keep doing it? And that would be your cone for that section. Let's say the patient has been giving you a timeline of a range of symptoms, and they say, and then one day last week I had a day of diarrhea. So a very open question at this point would be, tell me what happened that day. And that's going to get all information that the patient thinks is relevant about the occurrences of that day. A not quite so open question would be, tell me about the diarrhea you had that day. And then a closed version would just be a series of closed questions. How many episodes did you have? Did you have any abdominal pains? Did you pass any blood? So they're all going to get some relevant answers, but let's say in our hypothetical scenario, the closed questions found he had 2 episodes, there were some cramps, and there was no blood. That's all the information you found. The moderately open question found out there was a bit of nausea, and then cramps, and then some looser stools. The very open version, tell me about that day. Oh, well, I had some sweats in the morning, and after about an hour I started feeling really sick. I didn't actually vomit, but I felt really sick, and about an hour after that I started getting these really bad stomach cramps, and then I had explosive diarrhea, and it seemed to ease off, and then I had another episode of diarrhea, but by late afternoon it all seemed to have passed, and I kind of felt a bit weak, but otherwise I was okay. I actually ate something that was a bit out of date in the fridge the day before, and I think it might have been that. So it hasn't taken too long for the patient to say this, and in fact it's probably not much different to a series of closed questions. But the doctors who ask the closed questions, or the not so open question, is trying to work out how this diarrhea and abdominal pains fits into the overall presenting a plane. Whereas the doctor that asked a very open question and allowed the patient to tell them their story has found out it's almost certainly nothing related, and they can put that to one side. The other good thing about the timeline questions is that, and there's another video on this if you haven't seen it already, but asking the question, take me back to the start. Tell me what happened then, and can you talk me through what's happened from then until now? As well as being a question, it's a signpost. It's saying this is what is going to happen for the next few minutes in the consultation. So if a patient says something that's interesting, you can set up a cone to find out about that symptom or that thing. And then when that's done, you can then say, so it could be, tell me a bit more about the nausea you had. And then you can say, okay, thanks. So, okay, what happened next after that then? Is that you're redirecting the patient back to the timeline again. Let's have a look at another example. So let's take a headache consultation. So you start with, how can I help you today? And the patient gives you sort of bits and pieces of symptoms. So you decide to do a timeline question. Can you describe one of your headache episodes? Take me right back to start. How does it start? And talk me through it through start to finish. And they give you a bit of information, and you have a bit of input, such as a facilitating question, and what happened then, and maybe a closed question here and there just to clarify points. How long did that last for? Just to clarify points as you're going along. But no neurological symptoms were mentioned, so you want to check for these. And instead of asking a series of closed questions, did you have visual symptoms? Did you have a strange taste? Did you have a strange smell? Did you feel dizzy? You decide to do a very open question. Do you ever get any other symptoms that might be associated with the headaches? So this will capture all additional symptoms, not just the ones that pop into your head at that time. So there, it's a lot easier than thinking of lots of closed questions. If there is a symptom, then you can start working on a cone for that symptom. So, can you tell me a bit more about the nausea you get with them sometimes? And then you might need a closed question to fully understand it. So if you've watched the purpose of the consultation video, which was the last one I put on, you might be thinking, I might prescribe this patient a tablet for nausea in the management plan. So a good closed question to end this cone would be, do you feel like your nausea is bad enough that you'd want to take a tablet for it sometimes? And then that would determine whether that will become part of your plan or not. I think that was all I was going to talk about. So there's no doubt at all that very open questions gain more information. The other advantage is they're really easy. It's a lot easier to ask a really open question than it is to think of multiple closed questions, because closed questions get a short answer and then you have to think of another one. So they're actually quite hard to do, and it's quite time consuming working through them. What I would ask you to do is try your best to listen properly to patients. Let them tell their whole story. Try not to interrupt them with closed questions if you can help it. So really don't ask your next question until the patient stops talking. Try not even to think of another question until the patient stops talking, especially if you know you can fall back on a very open question. Can you tell me a bit more about, or what do you mean by? So you might log something you might be interested to ask about, and then when the patient stops talking, stop, pause, have a think about your next question. There's good evidence that patients can tolerate pauses a lot better than doctors do. Doctors feel they have to fill the time all the time, but patients don't mind if you stop and have a think and then think about your next question. So, summary. Look out for these points when you're consulting. Look out for points where you're going to start a new cone. Start as open as you possibly can, and then redirect and then direct the patient to the point where you feel you've got the information you need. Be aware of how you phrase the questions, and reflect: has the patient understood what I'm asking? Do I need to rephrase this? Do I need to think about how I ask this differently next time? Try and let the patient finish before you ask the next question. Okay, good luck.